Wish TV is focused on family and the community and is committed to sharing the stories of those who are making a difference every day. From the All Indiana Podcast Network and Wish TV, this is Behind the Eight Podcast with Wish TV's George Mallet.
This is George Mallet with Behind the Eight. On Monday, February 13th, Wish TV hosted a Health Spotlight Town Hall special. The focus of that special, the fact that racism is a public health crisis. News 8 hosted leaders from 4 of the top healthcare systems in Indianapolis: IU, Eskenazi, Franciscan, and Community. It was a landmark broadcast with healthcare leaders answering tough questions about what they're doing to address racial disparities in healthcare. In a moment, I'll be joined by Wish TV's news director, Al Carl, for a discussion about the importance of this town hall broadcast.
What can 160 years of experience teach you about the future? A lot, especially when it comes to protecting what matters. At Pacific Life, we've helped people and businesses confidently embrace the future with life insurance, retirement income, and employee benefits. With strategies built on strength and trust, and a promise to be here for you today and tomorrow. Ask a financial professional how Pacific Life can help you today. Pacific Life Insurance Company, Omaha, Nebraska, and in New York. Pacific Life and Annuity, Phoenix, Arizona.
And I'm joined now by the news director at Wish TV 8, Al Carl, for a discussion about racism is a public health crisis, a recent town hall that we held. And Al, give me a sense of what went into the origins of this program.
I think, George, first of all, you got to think about what that title even means. Racism is a public health crisis. It's not asking a question.
Right.
It's making a declarative statement. So what really has gone into this is a couple of local organizations, namely the Indianapolis Recorder, which is the oldest African-American newspaper in the nation, continuously run since, I think, 1895, and along with the Greater Indianapolis Branch of the NAACP. Those two organizations, for the last several years, have really wondered what they can do to help that constituency in this city and in this region that is underserved by the medical healthcare system. So what they've done is, over the last couple of years, they've taken it upon themselves to get some of the major hospital groups in Indianapolis together to talk about it. And they've actually had their own town hall meetings on Zoom and in other formats the last 2 years. This year they said, what if we can get a local television station to do it with us? And they, along with our hospital partner, which is Community Healthcare Systems, and we do quarterly town hall meetings with them as it is, they felt like if they could get community health interested in this subject, that perhaps they could get some synergy with Wish TV. And that's exactly what happened. So it was a committee, including the folks from the newspaper, the folks from NAACP and Community Health, that made this thing happen. And so you had the four of the major hospital groups in town, including Eskenazi, Community Health, IU, and Franciscan. Those are 4 of the 5 biggies in the state. Were all on our set talking about that one question.
And that was important because, and correct me if I'm wrong, this is the first time you had 8 leaders from those 4 institutions all sitting down together to talk about a specific problem.
100%. And it was really historic in that manner. These are major hospitals and their CEOs. It was the top person from each hospital and each hospital group that was willing to sit down and talk about their commitment to addressing this issue moving forward. So they broke it down into really 3 questions, and they were, what have we accomplished over the last 12 months? What do we hope to accomplish over the next 6 to 12 months? And what can you, the patient, do to help out? And so it was totally an opportunity for the hospitals to acknowledge that there is a disparity in healthcare, and how can they be a part of that solution.
And there really is empirical data that shows being black is hazardous to your health, and not just here in Indiana.
I'll give you an example. One of the subject matter areas was infant mortality and infant death rates. In the black community, black women are 50% less likely to get prenatal care in the first trimester. And prenatal care in that first trimester is a main predictor of whether your child will be healthy or have a healthy birth weight. And that's a huge problem in the black community. So how do you address that? What are the mechanisms to try to fight that? Is it education? Is it access? Is it the way people feel culturally when they walk into a hospital? And those are all the questions that they tackle. And it's looking at all aspects of healthcare. So they have to look at some of the things they need to improve on, and they're trying their best to do that.
I don't want to get too far into the weeds, but does this represent sort of a changing role for us in local television news in terms of becoming advocacy journalists?
Yeah, look, George, you've been here long enough now to know that Wish TV is, we really feel that we are the community television station, and you know that from being in other markets, and myself too. You work in other markets, and you come to a place like in Indianapolis, work at Wish TV, where we're locally owned by Dewan McCoy, who grew up here in Indianapolis in Hawville, went to high school here, went to college here, and got his first television job here in the city before he went off to be a broadcaster and ultimately own television stations. And because we're locally owned, we really feel a commitment to the community in a very significant way. And of course, Dewan is himself a minority owner, one of only 2% of all television stations owned by a black company. So he feels very strongly about that, and this television station feels it's part of our fabric. So yes, it's advocacy journalism, but for all the right reasons. We're here to help support underserved portions of our community.
That is Al Carl, our news director. When we come back, we're going to hear some highlights from the town hall. Racism is a public health crisis. Thank you, Al.
You're welcome.
From Wish TV and Community Health Network, this is a Health Spotlight Town Hall Special.
Good evening to you, and welcome to this Health Spotlight special right here on Wish TV. For the next hour, we want to focus on a specific powerful statement. Racism is a public health crisis.
More than 250 state and local governments and other organizations have made that declaration around the United States. Here in Indiana, 6 communities have done it, including the city of Indianapolis, nearly 3 years ago. In the past 2 years, the Indianapolis Recorder and the Indianapolis Branch of the NAACP have gathered top healthcare leaders to address that issue.
Tonight, we're proud to work in conjunction with both groups, and for the first time, those hospital leaders are here to answer those questions live on television, including questions that we've received from you. So let's go ahead and introduce you to those healthcare leaders right now. Dr. Lisa Harris is the Chief Executive Officer for Eskenazi Health. She's served in that role since 2003, but she's also worked in patient care, research, and teaching at Eskenazi for nearly 40 years. Dr. Harris is a past chair of the board of directors for the American Red Cross of Indiana. Thank you so much for being here. Diane McDaniel is the Senior Vice President and Chief Diversity, Equity, and Inclusion Officer for Community Health Network. Diane joined Community in 2020 as the first person to hold that position with Community. She also chairs Community Racial and Social Equity Steering Committee and is fabulous while doing it.
And we also want to welcome in Dennis Murphy, the President and CEO of IU Health, the largest healthcare system in Indiana. He's been with IU Health for 10 years now. He also serves on the board of the Indiana Hospital Association, Indianapolis Urban League, and is the chair of the American Hospital Association Price Transparency Task Force. Good to see you, sir. Thank you for being here. And Dr. James Callahan III is the Senior Vice President and Chief Operating Officer for Franciscan Alliance. The group operates 12 hospitals in Indiana and South suburban Chicago. He has previously served as president of Franciscan Health, Indianapolis, Mooresville, Carmel. He's also a fellow of the American College of Healthcare Executives and the American Academy of Family Physicians. We want to thank you all for joining us tonight. Obviously, the resumes speak for themselves, and for being part of this series of discussions with the Recorder and the NAACP. Thank you very much.
And you all have been having these kitchen table conversations for a while now, and I think that we need to start with this. We've heard the theme tonight. Racism is a public health crisis. But it's hard to answer questions without defining what this question means to each of you. So that phrase, what does it mean to each of you? We'll start with you.
Well, first of all, I want to thank the Indianapolis Recorder, the NAACP, and Wish TV for pulling this together. The effort taken to put this together. This is important work. And as we have dug deeper into the work, I have found myself thinking about what we're saying and also maybe perhaps what we're not saying when we frame racism as a public health crisis. There's no question the systemic racism, by limiting opportunities for education and jobs and housing and transportation and nutrition and health care, has negative impacts on health. These social determinants span across generations and entire communities, and it's the responsibility of those with us within healthcare to work within and with our communities, with the communities leading the way. They know what they need to address these issues and to reduce barriers to care. And we are all doing this work. And so, for example, when I say that Eskenazi Health, with its origins as City Hospital, and tasked with caring for all residents of our community, regardless of ability to pay, exists to promote equity, I believe I'm making a true statement. And however, as I talk with our patients and their families and our employees and individuals within the community, I've come to appreciate that healthcare itself can represent a barrier to care, that there are deeply rooted and highly valid reasons for mistrust that are not easily dispelled. So, for example, it's also a truth that we need to own that the few Black graduates of the IU School of Medicine who tested into internships at City Hospital in the early 20th century were not allowed to eat with their physician colleagues in the dining room, but rather required to eat with the Black employees in a segregated part of the dining room. So this is just a couple of generations ago in our community, and these stories die hard. And this is why it takes time and effort to build trust. And when a Black or an ethnic minority patient gets poor health care, or their concerns about their care or their complaints about their health care are dismissed or not taken seriously, that erodes, that destroys what fragile trust we might have built. And they feel devalued, unseen, ignored, hurt, and they become reticent to seek care. And as their negative experiences resonate through their families and their neighborhoods and their communities, that creates the barrier to care for which we are uniquely responsible and that we need to keep top of mind as we address the breadth of racism's impact on public health.
So many different layers to this definition. Yes. How about for you? How would you define this statement?
Well, first of all, I too echo just thank you for this opportunity, and to the Indianapolis Recorder and the NAACP of Greater Indianapolis. I think I'm in a unique situation at Community Health Network, heading up diversity, equity, and inclusion for our health system, because we partner and we automatically know, first of all, that racism, we haven't solved that problem yet in the United States. And so here in Indiana, in collaboration with the other three systems, we are collectively looking at ways and listening to the community, because after all, who has the pulse on knowing what the wants and needs and expectations of the community is, but the community itself. So solving this problem and looking at, because we are a multicultural environment that we live in today, being in tune with those needs. And that's basically the social determinants of health. Also looking at how our patients, how they feel secure and safe within our walls. That's important. But also looking at our communities that are marginalized and making sure that we are aligned and we are hearing. And that's basically our ongoing, constant conversation. It's not one and done, it's forever. And that's basically looking at, keeping aligned, and trying collectively together to solve what seems to be an age-old problem with racism in the United States and also within our community. But as a healthcare system, we owe it to staying in there, doing the work, and solving this issue.
Dennis and Dr. Callahan, I want to get you gentlemen in as well. Dennis, we'll start with you here on this one.
You know, I think the definitions are really important, and we think about it as those things that impact care that are not directly related to the direct provision of care, and they probably fall in two fairly large categories. Dr. Harris referenced one. We actually use the word social impediments to health, because the idea of things being social determinants means they're not changeable. And we actually think these things are changeable. So that could be, are you living in an area close to pollution? Do you have access to good education and good jobs? Are you safe in your neighborhood? So are you able to avoid gun violence? So there are a whole series of those impediments that actually have a huge component of how your health is. Some researchers believe that's about 80% of your health is actually determined by things other than the care that you've actually been given.
Wow, that's a big number.
And so it's a huge part, I think, of what all of us believe is that we have to get outside the four walls of our organization if we're really all kind of imbued with this idea that we have to make Indiana a healthier place. That's our job. And so that means getting outside our four walls. The second dimension, I think, is also really important, and I think Diane referenced it. It's what happens when you're inside our four walls? Do we treat you with respect? Do we genuinely hear you? Do we ask questions that make you comfortable, that you're willing to be a partner in that care with us? And so I think it's our responsibility to deal with both of those dimensions holistically and fully if you're really going to try and make a difference in this space. And I think that's why we believe it's a crisis, because we see the data shows that we're not dealing with either one of those dimensions as well as we could.
Dr. Callahan, we want to get your thoughts on this topic as well.
And as has been said, we want to get out in the community and really understand those health inequities, see where they're occurring. And for us as a Catholic health system, placing that in the context of respecting every life that we're privileged to serve. But then what we've been doing, we want to build the processes and the structures to learn about those inequities and then address them and improve them. And we've been working on that together.
Easier said than done, I'm sure, and we'll talk with you folks in a moment as well. A big part of this effort over the past 2 years has been collecting data to help improve healthcare for everyone here in Indianapolis. Now, for the first time ever, we're going to reveal some of that new data for you. Alexis is with Dr. Patrick McGill, Chief Transformation Officer for Community Health Network. Alexis.
Phil, thank you so much. Dr. McGill, thank you so much for being here with me. You know, I know that a big key factor that many of these folks have been working on is just trying to figure out how to have and develop data on patients. Before we get into the specific numbers, let's go ahead and talk about why having that type of data is so important.
Absolutely. You know, having a robust data set to understand where we are and where we would like to go is so important, so that we're all talking the same language. We're talking about the same measures of success and understanding where the differences are so that we can focus the health care for Hoosiers, for all Hoosiers across the board.
I don't know about you, but I'm a visual learner, so let's go ahead and dive into some of these brand new numbers. This is based on patients that have been going through any of the 4 healthcare systems that we have here tonight, correct?
Right, correct. So we wanted to start with a common set of patients. So we started with everybody who lives in Marion County, so they have a Marion County address, who has touched any of the 4 systems represented tonight. So that could have been in an inpatient admission when they got admitted to the hospital, an ER visit, or a visit with their primary care physician or specialist. Could have been any touch that they had. We wanted to look at that data And we've really leveraged the Indiana Health Information Exchange for that data set because it's so robust with all the health systems submitting data.
That sounds like a lot of people.
It's a lot of people. It's a lot of people.
Let's go ahead and break down some of those numbers here. Let's go ahead and start by talking about diabetes and the population in Marion County.
Right. So what we want to start with the first disease state, which is diabetes, or think about diabetes, it's irregular or abnormal blood glucose control. And so that is the number one cause. When it's uncontrolled or untreated, it's the number one cause for blindness, kidney failure, and amputations in the United States. So it affects so many Americans. We wanted to focus there. So what you're seeing here is that there's 6 common tests that all diabetics should have. So we looked through the tests, we looked through the data, and said, okay, how many people, Marion County, again, touching the 4 systems, had 5 or 6 of the tests. So what you'll see is 62% of all the patients in the data set had 5 or 6 of the tests that they should have. Now, when you break it down by race, only 57% of white patients had 5 or 6 of the tests, but 70% of black patients, black African American patients, had those tests. And you can see across the other races, 62% Hispanic, Latinx had 5 or 6 of those tests. So that's really important. Are they getting the care that they need? Just the basics, doing those tests.
Now, that seems like a pretty large disparity there. Do we understand why those numbers are the way that they are?
It could be education. It could be the level of care that they came in. Were they coming into primary care, or were they touching in the ER, where it might have been emergency care and really diabetes wasn't the focus? So we really didn't want to discriminate against any of that. Look at, were they just getting the test? And I think this is really where the question starts to get really interesting, because as you see the control, let's just stick with A1C, which is really a marker of diabetes and sugar control. So you'll see that overall 60% had that under control of all the patients. 66% of white patients had their A1C or sugar under control, but only 57% of black African American patients had it under control, and down to 40% of Hispanic and Latinx patients had it control. So that means that we're doing the tests, more people were having the test, but less black African American patients actually had their sugar under control.
And it goes back to putting some context with the data that you have. So let's talk about another key part of this when it comes to data. When it comes to infant and maternal health, that's been a big item. We have talked about that a lot within this Health Spotlight series. But when it comes to prenatal care for women, especially women of color, this has really come to the forefront. My question to you is it because now we know more? Why are we talking about this more? Because it seems like the problem has been there for a while.
I think the problem has been there for a long time. I think we now have a robust data set to really show. We've known that the outcomes between white and black African American mothers have been different for a long time. But it's really understanding the data to understand why that is and what can we do about it. So when it comes to maternal and infant mortality, we know that prenatal care is the number one thing you can do, early prenatal care in that first trimester. And so when we looked at the data in Marion County, all the patients that have touched our systems, we see that black or African American mothers were 2 times more likely not to have prenatal care in that first trimester. That first trimester, when it's so important to get care early, we saw that there is a big disparity in women of color.
Now, being a black woman, I see that, and that completely makes me shudder, because that means that, how many of my friends, if there's 4 or 5 of us in a group, that there's a good majority of us that are not getting what we need.
Exactly. And so we have to understand why that is. Is it because of some of the concepts that were talked about earlier? Comfort coming in, being welcoming coming into the system. Do we have care in the areas where women live? Are we bringing care to them? Do they understand the importance of early prenatal care? I think those are all of the conversations that we need to start having collectively to really start to address this.
I'm in that age where a lot of my friends are having their first sets of children, really, and we're talking about this. Birth weight has seemed to be a very big topic of conversation. Let's go through this data.
Exactly. So we looked at low and very low birth weight babies. So low birth weight's defined by less than 2,500 grams. Very low birth weight is less than 1,500 grams. So very small. So when you look at the data, about 2 to 3 times more black African American mothers will have babies of low birth weight. And that translates down into very low birth weight, about 3 times higher for Black African American mothers.
Now, putting context to what we're seeing here, again, what's the story behind that? Is that a nutrition thing? Is that an environment thing? Why are we seeing these numbers this way?
I wish we could tell you from the data. I think that's where we have to commit to understanding more. Is it early prenatal care? Is it nutrition? Is it controlling blood pressure in pregnancy? Is it diet? Is it some of those social indicator factors that we're talking about earlier? I think that's all part of that story and so important.
Absolutely. And I'm so happy that you're giving me visuals here. I believe we have another set of data
I have one more.
to just give us a bit more context of what our neighbors and our loved ones are going through.
Exactly.
So let's talk about preterm birth.
Yes, so the same thing. We're looking at preterm birth, so mothers that deliver early, 28 to 31 weeks, or very early, extremely preterm, 22 to 27 weeks. And so what you see is Black African American mothers 2 times more likely to deliver very preterm, and extremely preterm 3 times more likely. And again, same story. Why is that occurring? Is it related to care? Is it related to interventions in care, controlling some of those gestational diabetes, high blood pressure? What are all those factors? That's where we have to really lean in and understand. We understand them. We know many of the factors, but what can we do about them? How do we engage at the right time to really make a difference?
I'm so happy that you broke that down for us, because these are the conversations that we're having amongst ourselves, but we need to be having them with people just like you and our neighbors. So let's talk about diabetes, because I know our blood pressure rather, because I know that this has been something that's been huge in my family, and I feel like we talk about it, but we don't get very far.
Exactly. So diet or hypertension or high blood pressure, hypertension is so important. It impacts so many Americans, and especially Hoosiers. It's very prevalent with Hoosiers. And so when we looked at the data, there's 2 things that we wanted to look at. Was your blood pressure monitored or measured when you went in to see the doctor or provider, and was it under control? So when we looked at the data, the top is, was your blood pressure taken and recorded? So that should be something to empower people. When you go see your provider, take my blood pressure. Why did you not take my blood pressure? So what we see is 69% of white patients had their blood pressure taken. 80% of Black African Americans had their blood pressure taken. And this is 2018, 2019, 2020. So you can see a little bit of a drop off into 2020. Is there a little bit of a COVID impact here?
Sure,
Could
but
be.
you saw an increase here in 2019.
Right. And then the bottom is, so was your blood pressure taken? The bottom is, was your blood pressure controlled? So where you see it's a huge drop off. Of the 80% of Black African Americans that had their blood pressure checked, only 70% were controlled compared to 77% of whites. So there's a drop off in control. Again, it's education. Could it be related to diet? Is it blood medication adherence? Can they afford the medication? Are they taking the medication? Are they following up regularly? What are all those factors? That's where we have to lean in and help people understand why it's important, and then help them with the needs that they have to address those concerns.
Helping people is the charge, and I think with what we're learning here today, we'll be able to do that. Matter of fact, I'm going to go ahead and pitch it over to my friend Phil, because he has even more ways we can help.
What an amazing conversation, right? Good stuff right there. So I want to welcome back in our healthcare leaders. Ladies and gentlemen, you saw the data, eye-opening stuff. And Diane, I want to go to you first on this one. What have we learned from this data?
We learned.
And are there any surprises?
We learned for sure some of the things that we thought or perceived as far as lived experiences are actually there. We're able to actually see and touch the data. And plus, as Dr. McGill just stated, it gives us opportunity to dig deeper, to try to find out more around the why. Yeah. As far as surprises, there were some surprises in the data when looking at it for me. Having been, and also in my family, hypertension has been there for a number of years, but to see the actual impact in the Black and African American community, it becomes real. So as far as a surprise there, no, but seeing, knowing that there is a lot of additional work that needs to be done and it's up to us to do it, yes.
Dr. Harris?
I've practiced with Eskenazi Health for about 40 years, so I'm not sure that there were many surprises. I've cared for patients with diabetes and hypertension, and I know these
Maybe
issues.
Not surprises, but do those numbers help you?
They do. I think they proved out something that we know to be true, and our patients and our communities know to be true, and that is we know that nutrition is at the foundation of all these chronic diseases that disproportionately burden our communities. And so looking at this helped us realize that we need to add something else to our data collection. And so we started screening all of our patients for food insecurity because we know that 80% of chronic disease can be prevented, better managed, and in some cases reversed by good nutrition. As Dennis was referring to this.
I was going to say that, Dennis, you were just talking about that, right?
And so we've added, so we think that right along with getting all these measures and blood pressures and A1C, all the things we need to add a hunger vital sign. So we're screening everyone for food insecurity. And turns out about 30% of our patients are food insecure. And we have a whole host of interventions that follow from that I'm happy to talk about if we have time later. I don't want to take that all the time now.
Sure.
So that's something that we have put in place as a reaction to the data. I think the thing that is exciting about this is seeing that we can gather these data, we can get the large numbers that allow us across the community to see if we're really making an impact, much more than we can tell if we only look at the data within each of our health systems. The concern, though, is that we know that about 30% of patients are reticent, they're uncomfortable sharing information about their race, their ethnicity, and their preferred language. So to make these data most robust, we know that we need to work to get all those gaps filled in so that the data truly reflects the issues and points us in the right direction of where to focus our efforts. And so we're going to be talking about the campaign around that.
We're going to have that coming up here momentarily. Dennis, I want to get you in here as well because it almost underscores what you talked about before in regards to how much of this is social, correct?
Absolutely. I think the data for us collectively, I think we all committed to the idea that this is actually a crisis. You have to understand kind of that underlying baseline of where are we at today. I think Dr. McGill said a couple times, now we know we have to do something. We have to understand better where those interventions are. But even for community and IU Health, this has led to a program called iHeart, which is actually funded by a medical company that's actually allowing us to do hypertension screenings and interventions around cardiovascular care. We've done that with 3,500 people already in 150 different screening events.
Wow.
And so I think for us, this is going to be a process of understanding those things that are driving the data you saw, and then developing interventions. I love Dr. Harris's comment around not only understanding the food insufficiency, but having a set of interventions that make a difference. I think that's what all of us are seeing this data begin to tell us is where do we need to build interventions, and ideally, as years go on, are the interventions effective? Are they making a difference?
Dr. Callahan, I want to get you in here too because we're almost out of time before we go to a break. How does the data help tell the story and also really kind of give you a goal to reach?
Right, so we saw two parts of the data. One is how do you get to folks to get these things measured, the blood pressure and the blood sugar. That's just part one, though. Part two is how do you treat it? And how do you educate people that these are not abstract numbers, blood pressure and glucose numbers. They're risk factors for having a heart attack and a stroke and all the things that Dr. McGill said. So that's the education that has to happen.
so many layers to this, but I think we're peeling them back one thing at a time, that's for sure.
We're trying.
Definitely
You folks are trying.
Welcome back to the Wish TV Health Spotlight Town Hall Special. We are so proud to work in conjunction with the Greater Indianapolis Branch of the NAACP and the Indianapolis Recorder on tonight's event.
In fact, this is the third town hall hosted by the groups to talk equity in healthcare. So tonight, we welcome in the leaders of those two organizations.
Good evening. I'm Crystal Ratcliffe, the president of the Greater Indianapolis Branch of the National Association for the Advancement of Colored People.
And I'm Robert Shigog, President and CEO of the Indianapolis Recorder newspaper.
For more than 110 years, the Greater Indianapolis Branch of the NAACP has worked to ensure the political, educational, social, and economic equality rights of all persons. It's why, for the past 2 years, we've urged leaders of the healthcare systems to make commitments to health equity. We're committed to continue asking questions of healthcare leaders to reach that goal for everyone.
The Indianapolis Recorder newspaper has always been a major voice for the black community since 1895. The Recorder has always been an advocate and a voice for the voiceless. This is why we are committed to these town halls and to educate and motivate the community and preserve the community's knowledge on important issues.
We thank the hospital executives who have joined us tonight, and we thank you for watching.
And of course, we are so excited to not only have the amazing folks from the NAACP as well as the Recorder, but these amazing folks that have been working so hard, welcoming back our executives from the Indianapolis healthcare systems. One of the key things for us to talk about tonight is what can be done in the next 6 to 12 months? What specific plans and goals do you all have this year to try to address equity and equitable healthcare? Because I know how your brains work. You know, we have to be very specific in our time frame here. But what do you all have in store? Let's actually start on this side and work our way.
All right, well, thanks. Well, partnerships in the community are key, and so you know, working on reducing diabetes, working on blood pressure, and preventing heart attacks and strokes are so key, as we've been talking about. So one thing we do is try to achieve grants to reduce these health crises. So we have one in effect to reduce diabetes in our African American and Burmese and Sikh populations on the south side of Indianapolis, and another for suicide reduction in the African American community. One thing we're doing is learning from our fellow hospital colleagues, and we have one of our hospitals in South Suburban Chicago, and there we've used community healthcare workers to go into the homes, often of African American patients, to monitor the blood pressure and diabetes, as we've talked about. And we've made some improvements in the kinds of metrics you and Dr. McGill were discussing, and we expect to do that this year here in the Indianapolis area.
Very intentional, absolutely. How about you all?
You know, I think it goes back to those two dimensions again. What do you do outside? So we at IU Health have set aside $200 million for community impact investments. And so that goes back to those social impediments to health. How do we think about food access? How do we think about job skill training so that people can get jobs? Because we feel like that's a critical component. How do we think about behavioral health issues in the community? And then I think within our four walls, it is some of the things that Dr. Callahan talked about. How are we addressing, importantly, I think, infant mortality? We've created a doula program.
Which is huge. A lot of people want doulas nowadays. Yep. That is like the thing.
And importantly, black doulas, so that there are people from the community serving people in that community. Also, I think childhood immunizations go hand in hand with, I think that infant and maternal mortality. So we actually have caseworkers actually taking the time to explain the importance, because I think through COVID we've learned there's probably a lot of misinformation or disinformation about the importance of vaccines, and we want to get back to let's have a conversation, let's explain what that means to those patients and
Dennis,
their families.
I just want to follow up. You know, it's hard to talk about healthcare without talking about cost, right? Yep. Financially. How do we help people out when it comes to that?
Yeah, I think for all the organizations you see here, we all have really robust charity care policies. And I know for IU Health, all of our providers, whether they're physicians, nurse practitioners, or physician assistants, they're not incented to see any one patient over another. They treat all people equally. And so I think the key is, again, a conversation. We have financial counselors that will help people get enrolled in the appropriate programs. And if not, we will help care for them just through charity care. You know, I think one of my core messages is trust us. That come to us, tell us what is going on, tell us how we can help you, and we will engage. We will find ways to care for you, because I do think that barrier of, oh my God, I can't afford to get care is part of that social impediments to health, and we're here to help. And I mean that collectively. All of us want that.
That's huge. That's a conversation that many of us are having. Let's get specific here, and we want to hear from you all as well. I'll start with you. You know, Black and Hispanic communities, many Black and Hispanic communities, have proven to have difficulty having the resources, as we were just talking about, to try to get the help that they need. So how can your health organizations try to not only help them get the resources, but really help them with the confidence to even know where to look? Because speaking from experience, I had no idea that I have a social worker that I can just reach out to, no matter who I am or what I make.
Okay. Well, first of all, I do want to share with you that this year we have in place, it's a diversity, equity, and strategy plan. It's a 5-year plan that was developed last year by 26 of our employees. And our employees, we refer to them as caregivers, but designed this plan. And health equity, it's a 6-point focused plan, but health equity is at the core of that plan. And part of that, when you ask about the Latino communities and other communities, a part of that is educating. And that it starts from within, educating our workforce, but also reaching out to the community to provide additional education regarding this is a safe place to be, you are welcome, and basically sharing how we can come along beside to address any question that you might have, any health concern. But I do want to share something. That Community Health Network is in our school systems. We have a school partnership there, and 650 of our employees, our caregivers, are in over 150 schools in the Indianapolis area, where we are providing services for our youth, and that's on a daily basis. And over last year, there were over 1,000,004 visits for children that are in the school system to asking for health care. So as far as being able to reach folks that are needing additional services, like our Latino population, we have iPads there that will help with assisting with language concerns, that will basically help to communicate what those needs are and for us to be able to answer those.
Dr. Harris, you want to?
Well, I'm trying to decide which of these things to dock into. I think, you know, for the majority of our history, most of the patients we care for have you know, been uninsured, and certainly Medicaid expansion has helped that to a great extent. But we have over decades built up, armies of financial counselors and social workers and interpreters, and that's just part of the fabric of care. But we have made that much more intentional by working again out into the community. We now have community health workers that emanate from the health system out into the community, dozens of community health workers, but also community health weavers that are coming from the community. We know that the community knows what the community needs. They know what resources they have. And so we are getting much more deliberate about that work within the communities. And so, for example, around 3 of our health centers, we are now describing health equity zones, where we are working very intentionally with the community leading the way. The neighborhood organizations in those communities are leading the way, convening dozens of partners. We're just one of the partners in these efforts, and we will be looking at the same kind of data that we're presenting here, and seeing the effectiveness of this particular approach. I think we already know from talking with the communities that, again, that the nutrition, they recognize that as the biggest problem. So that's why we have really doubled down in terms of being able to not just screen for food insecurity, but when we identify individuals who are food insecure, we link them with individuals who are on our team only to get them enrolled in the Supplemental Nutrition and Assistance Program.
And it's so awesome that there's so many intentional efforts as well. And we'll continue to peel back the layers. We're getting to know how the sausage is made.
Oh, yeah. Oh, yeah, we are. I want to welcome in a very important guest tonight, Dr. Bronson Tucker Edmonds, Vice President and Chief Equity Officer at IU Health. Doc, good to see you. Thanks for joining us.
Thanks for having me.
Absolutely. This is an important one. Okay, so we ask because we care program, something we've talked about several times tonight. What exactly is that?
The We Ask Because We Care program is actually adapted from a program rolled out at Henry Ford Health System. And the idea of the program is to help us increase our capture rate around information regarding patients' race, ethnicity, and their preferred language. This is important. It's actually really critical to several of the conversations we've already had tonight. You saw the data that was put forward. That data is only as good as the information that we're provided from our patients in their encounters with the health system. And so if people are feeling reluctant or skeptical, as Dr. Harris suggested, to provide us with that data, then we have these gaps, right? And we may be drawing incorrect conclusions. We may not have the best information to guide our decision making.
So it's very important to get the correct information. We'll get into how you do that here momentarily, but it started back in October of 2022. Is it working the way we hoped? And I just wanted to step out to give you all a good view of what we're talking about here. Absolutely. So one of the things that I can speak for our health systems, but I also know with our partners that we've been working with, that we are seeing steady increases. At IU Health, we started our year at 82% of our patients had a recorded race, ethnicity, and preferred language on their record. By the end of our year after the campaign, we saw those rates up to 89%. So we are seeing them trend upward, and we're hoping over time to exceed 95% of our patients, meaning that for 95% of our patients, we've got race, ethnicity, and language captured in their health records. Okay, so it's a conversation that you usually have with your doctor, right? But it goes further than that, does it not? I mean, you also talk about there's a marketing campaign as well. I mean, you've used radio, TV. Talk about this if you can a little bit, and how this helps tell the story. Absolutely. So it was critical for us to really contend with one of the real challenges is that patients are oftentimes skeptical because, yes, you have these conversations with your doctor, but you're also having them with the registration right when you come to sign up for care, right? And a lot of people were wondering, why are they asking me these questions? Is this going to help me? Is this going to harm me? How are they going to use this information? So it was really key, if we were going to improve the quality of our data, that we helped the full community understand why we ask.
we ask because we care. And so we actually collaborated across the 4 health systems, all putting a community-facing marketing campaign out. We ran more than 4,100 30-second sort of radio commercial spots, made more than 5.5 million impressions in the community across 4 different locales, and we did so in Spanish and in English in order to try to get the word out, to help people understand, why do we ask? We ask because we want to understand the communities we serve, we want to identify health inequities, and we want to be able to provide you with the best care that's really designed for you.
So let's get back to what we talked about here at the top, and folks trusting, right? And having this conversation, having to give the data. It's not an easy conversation to have because, as we mentioned before, about 30% are reluctant to give that information. How do we work against that? How do we make it work?
Yeah, I think that in large part, we have to show ourselves to be trustworthy, right? So we have to take good care of your information. It's confidential. It's not information that we're sharing with other parties. We're using it to provide care for you, and to really identify sort of how do we put resources in place to ensure that patients get the highest quality care. It's care that, these are pieces of information that we're obtaining really only to help and not to harm. But I do understand that we have some ground to make up to prove to all of our community members that we are trustworthy with their data and with their care.
It's a tough conversation. Dr. Edmonds, thank you for being here.
Happy to be here.
Absolutely.
Thanks.
Alexis, back to you.
Phil, thank you so much. We're talking about how racism is a public health crisis, and we're so proud to work in conjunction with the Indianapolis Recorder and the Greater Indianapolis chapter of the NAACP on this special event with the leaders of the largest healthcare systems here in Indianapolis. So we've talked a lot tonight about what the hospital systems have done, but let's go ahead and focus now on what you need from the community to achieve equity in healthcare. And when you hear that question, what immediately comes to mind for you all? So actually, Dr. Harris, I'll start on this side. When you hear that, when it comes to mind, what comes to mind for you when we're talking about what people can do to help you all?
Well, I think it's, again, there are resources that are out there, and I think the individuals within our community know what their strengths are and they know their needs. And I think that the role that the NAACP and the Recorder can play, and that opportunities like this provide, is that vehicle for helping people have a conduit to be able to provide us this information, and a trusted sort of a source. It's a source of accountability as well. But I think that again, it's really about recognizing how the strengths that exist, and that there's a voice, and that there's a forum for individuals and communities to be able to express the areas where they need help and point the rest of us in the right direction.
I think you touched on something that you and I were just talking about when it comes to the partnerships. Having trusted institutions like the NAACP and the Recorder to try to build trust in these communities of color, how important is that? And let's talk about partnerships.
Yeah. Well, we are fortunate because with building a partnership with the Indianapolis Recorder and the NAACP of Greater Indianapolis over the past 2 years, collectively our systems have basically allocated resources where we meet on a weekly basis to look at and to help develop the information that we just presented, to basically show the dashboards. And with that, that's giving us an opportunity to even take it a step further, because now we have the data. We've seen the surprises. We realize change is happening, but we still have a way to go. And so we have leveraged another part of our gathering, and it's a 15-member team that started initially, but we have now basically put in place a communication and education team so that we can delve further into the data that we just witnessed tonight. But that's a collaboration with the 4 systems, with allocating resources. So we're serious about this work, and we're serious about getting it done, and getting it done with excellence for our community.
You know, Dennis, I want to circle back to what Dr. Edmonds talked about, that 30% and how important it is for us moving forward to get the right data, to really kind of hit a home run when it comes to this and getting it accurate.
Yes, I think Dr. Tucker Edmonds started with what I would consider the kind of tip of the iceberg, which is tell us who you are and what's your preferred communication style, what language. You know, if you go back to that earlier comment around understanding those social impediments to health, we need to know that too. We need to have a discussion with you about do you have access to food? Can you get to the hospital or to your clinic? Do you have transportation? Do you feel safe at home? There's a whole set of discussions that I think for our systems then determine, can we bring additional resources to bear on your health?
Transportation, that's a tough one. It's a barrier, no doubt, right?
And you know, I think all of us have creative solutions. Some of us have worked with Uber to be a transportation provider for our patients. It's interesting. In more rural communities, that's harder, so you have to find other alternatives. But I think, again, the real data for us is the starting point of building that trust and then being able to get more information from patients to deal with those issues that impact their health care but are not straightforward clinical issues.
Well, let's assume that we're sitting in these chairs, you know, this time next year.
Yeah.
How do we know that all the things that we've been talking about and educating people at home about are working? What does success and equity look like?
So I think it goes back to your previous question, is how can we collaborate with the community? What can everybody do out there to act on these things? So go to the resources, whether it's through the NAACP or the Recorder, through our health systems. There are resources to improve health there. And also I would say to folks that look for the resources with regard to career possibilities. The healthcare sector is a large part of the economy, and we have great shortages of healthcare workers, whether it's paramedic or nurse or physician. There are education pathways that we can assist with to develop that, because you know, we want good health outcomes for individuals, but we want it for the community too, because that leads to better economic health.
You know, a lot of people don't get a chance to sit down and speak with you all, and I know our time is winding down. But each one of you quickly, if you could say one sentence to every family out there, just talking to them like you're talking to your kids or maybe your mom or your dad, what would that one sentence be? And I'll start on this end.
Oh, dear.
I know. But it's because you have a family.
It could be more than one sentence. Go ahead.
Just know that we know that these opportunities, we know that health happens or not in your homes, in your neighborhoods. It's where you live, work, and play, worship, you know, raise your families. We understand that. And we know that the opportunities for good health, for the circumstances, you know, reducing the impediments, as Dennis said. We know that to achieve equity, these opportunities have to be available to everyone, and especially those who historically have been, because of longstanding inequities, longstanding social injustice, have been been on the short end of the stick. Especially those individuals need all of our attention, and just know that if you let us know, work with us, let's work together so we can make things better.
We have about 90 seconds left. Diane, I want to get you all in here. So
yes,
go ahead,
quickly.
Diane. Final thought.
Ask questions. No, don't filter what you're thinking. Ask questions. Ask for help. Ask for clarity, and just continue to reach out, because we're all in this together.
Dennis.
Yeah, I would say be proactive. So advocate for yourself, go to the immunizations, go to the health fairs, the screenings, and talk to people. I think just being open about your needs is critically important.
Reach out and keep communicating.
Communication is the key.
That's right.
Okay. Well, hopefully we have this conversation and we keep moving in the right direction here in the future, in the months and the years ahead. Thank you so much for being here tonight. Thank you.
And thank you for being open to having a real conversation with us. And we thank you all for joining us tonight for this extremely special Health Spotlight Forum. Our thanks to the hospital leaders who have not only been here tonight, but have really just spent the time to be genuine and sincere with us tonight. We thank you for that.
Fantastic conversation. We also want to thank the Greater Indianapolis Branch of the NAACP and the Indianapolis Recorder for helping us bring the panel together.
This is George Mallet. My thanks to News Director Al Carl for joining me on Behind the Eight. The entire Wish TV Health Spotlight Town Hall Special, Racism is a Public Health Crisis, remains available at wishtv.com. Be sure to listen and subscribe to Behind the Eight and all of the podcasts available on the All Indiana Podcast Network.
From the All Indiana Podcast Network, this is Behind the Eight Podcast with Wish TV's George Mallet. Be sure to like, follow, and subscribe to this podcast wherever you get your podcasts. And connect for even more on Facebook and at wishtv.com.